Um, sinusitis. This is one where there's very little information here that's going to be terribly useful to you, and I think the most important information is going to be based on the last paper, which is not much of a paper at all, but which does remind us to talk about what really matters. But the more interesting, so what we're going to talk about for the start of this are sort of concepts rather than sinusitis itself, because sinusitis is sort of a poster child for some of the ways in which classically we think things that are probably not true or irrelevant or certainly not proven. So the first question, the first 3 articles or 4 articles deal with how do you diagnose acute sinusitis. So before I go to what the articles say, let me ask you, what's the sort of overweening question you have to ask yourself when you're looking at what's good for diagnosis? When you're looking at the test, the characteristics of a test, how good is the test? Whether it's, how good is a CT, how good is a chest x-ray, how good is a physical exam? What's the thing you really have to know before you can judge how well the test worked? So one thing is that in order to apply it to a patient, it's really, whatever the characteristics of the test are, you must know the pretest probability, because that's the only way you can know what, after you got the test results, what's the likelihood now. So that's a really important concept. That's called Bayesian thinking. And it says that if I start out with a 5% chance of a disease and I get a positive test, unless the test is really great, it's still probably pretty low, the chance that they have it. If I get a negative test and I started out with a really high probability, I would be very careful about saying they don't have it. But even before we get to that, there's one other thing. What are test characteristics? So when we talk about tests, what are we talking about? We're talking about how accurate a test is, right, and how reliable it is. And Billy was just talking about reliable means if you have different people looking at the same test, will they come up with the same answer? Or even if you did it yourself, you looked at the same x-ray twice, would you always agree? That's called reliability, which is the test-retest thing, reproducibility. And then there's accuracy. And what I'm trying to get at is when you're talking about accuracy, which is how well does the test tell the truth, right? When it says bleed, is there really a bleed? When it says no bleed, is there really no bleed? You have to know against what you're comparing it. It's really critical to know what's the gold standard. So what is a good gold standard for MI? What's the gold standard for MI? EKG changes. Is that a good gold standard? No, because many MIs don't have EKG changes. What's the thing that the American College of Cardiology will tell you is the gold standard for an MI today? Troponin, right? 10 years ago, it wasn't troponin. What was it 10 years ago? CKMB. Why did it change? What? Well, it was more expensive test, but it's also, they just made it up. They said, well, we think the CKMB is not quite as good as the troponin. Now, in order to say it isn't as good as the troponin, they'd have to have some other outside gold standard that they compared them to and said, you know what, the troponin is better. They didn't have that. They just said, we think some of the people who have a positive troponin and a negative CK, we think they really have the disease. So we're going to now change the gold standard. But whenever you do a gold standard, you have to ask yourself what it is. What's the gold standard for a pneumothorax? It used to be a chest x-ray. But then they started doing CTs, and they found a lot of pneumothoraces on CT that weren't on chest x-ray. Now, the first study said they disagree with each other. CT found these, chest x-ray found these. Sometimes they overlapped, sometimes they didn't. Well, if the gold standard is a chest x-ray, then when you say that CT doesn't agree with the gold standard, you'd have to say CT is wrong. But they didn't want to say that because they thought, you know what, the CT, we believe the CT. So they changed the gold standard. None of them did they open up the chest and look. If you think about gold standards in general, it's really an interesting, important question. So for example, one of my favorite examples is PE. What's the gold standard for a PE? Well, an angiogram, right? But we know that angiogram doesn't always get it right in some sense. How do we know it doesn't get it right? Well, sometimes the person dies and then you do an autopsy and there's a PE. So the real gold standard is an autopsy, right? Which is not a terribly practical gold standard. But how good is an autopsy for a PE? Well, if you actually really want to know, if you give the autopsy to 3 different pathologists, they'll often disagree. And not only that, but some of the times they'll see a clot and it occurred post-mortem. It's not a good gold standard. And sometimes you know there was a clot and it's been dissolved by the time that they do the post-mortem. So why am I telling you all this? Just to remind us that gold standards are sort of not really gold. Sometimes they're pretty good, and sometimes they're obviously terrible. And it reflects a lot about what's our best current belief. And it's really important because whenever you're looking at how good was a test, you ought to first ask, how good is the gold standard they compared it to? If the gold standard is rotten, you're not even worth talking anymore. And if the gold standard is really good, then you can say, well, how good was the test compared to the gold standard? So the reason we do tests is because you don't want to have to do an autopsy. You want to know without doing the autopsy. So you'd make your best guess. But that's all it is, a best guess. The reason I say all of this is because in sinusitis, the first few papers say, how good is clinical exam for diagnosing sinusitis? And what I always ask is, what was the gold standard? So what's the gold standard we use for sinusitis? If you look at these papers, it's sort of interesting because they all differ. Some of them, they use ultrasound. In Europe, they use ultrasound as a gold standard for sinusitis. In the US, we don't at all. Some of these papers, the gold standard for distinguishing sinusitis versus just a run-of-the-mill URI was, what did the doctor think? Well, that's pretty stupid. What did the doctor think? First of all, the doctor might not be right, right? Second of all, when you do a study like that, what did the doctor write down? So when the doctor wrote down maxillary tooth pain, that correlated with the doctor writing down as the diagnosis, sinusitis. At the end of the study, they go and look and they say, you know, the gold standard is what was the diagnosis, and guess what? Maxillary tooth pain correlated. Well, that doesn't prove that maxillary tooth pain really correlates with sinusitis. It just means that doctors think maxillary tooth pain correlates with sinusitis. It's a self-fulfilling prophecy. Every time I think this is really a good predictor, I write both of them down, and then sure enough, it's the truth. It's totally ridiculous. It has no scientific validity at all. So you always got to ask, what's a better gold standard? So what are the better gold standards that we've used for sinusitis? X-ray, right? You get an X-ray, see if there's an air fluid level. How good is an X-ray? Well, if it's the gold standard, it's great. But compared to other things, it's not very good at all. Compared to, for example, CT, it's not very good at all. How good is CT? 90% of people who have a common cold, if you get a CT, they'll have what's called rhinosinusitis on there. They'll have these inflammatory changes. So we don't know what the gold standard for this is. And it's, after that, everything else gets really hard because we're mostly making it up. It's mostly, what do we think? A really good gold standard might be you put in a needle, you take out pus, and you culture it. And if they got a bacterial infection, that's what it is. There are a lot of problems with that. What are the problems? We don't want to do it. Okay? Even in studies, they don't want to do it. You could imagine, let's do it in one bunch of patients, then we'll know the truth, and then we don't have to do it to everybody else. But there are very few studies which use that as the gold standard. In addition, even that's really not such a good gold standard, because if it's viral, it's really sinusitis, it just doesn't grow out bacteria. But that might actually correlate with the clinical signs. In addition, we know for everything for cultures, they don't grow out. Very often you have bacterial disease, you don't grow it out on culture. If you just did 3 sticks, you get a lot more positives. So maybe the gold standard should be a study where the person has 3 sticks to their sinuses. I mean, obviously, it's a problem. So the rest of what I'm going to tell you is mostly made up. It's mostly, here's what we think. It's not that it's true, because there is no really good gold standard. So the article number 1 is by a guy named Williams. 1 and 2 are by a guy named Williams, who's a famous guy in sinusitis. And he pretends that this is the rational clinical exam. It's number 2 from JAMA. It's part of their series. But it's really, here's what I think. It's really, that's all it is. And what Dr. Williams thinks sinusitis is is it's more likely if they have maxillary tooth pain, if they have pain in the maxilla itself and tenderness over the maxilla, and if they have it, if they have it for a long time, and if they have colored discharge. I love that. Colored discharge. What is colored discharge? No, it just means, yeah, it means inflammation. It means there's some white cells. Everywhere we know that every other place, colored discharge has no correlation with bacterial infection. In bronchitis, it has no correlation with bacterial infection. So I think that's just sort of silly. How about prolonged infection? That correlates with bacterial infection, right? No, absolutely not. Viral infections all last longer than bacterial infections. So, so probably, and bending over, yeah, but that's probably just because we've all been taught that. I mean, maybe it's true, but we have no idea if it's true. So I'd like to ask a slightly different question, which is, so first of all, how often is a cold, or if it really is sinusitis, how often is it bacterial? Well, it's hard to know. But probably the majority of the times, even if there is an infection in the sinus, it's not. So why the new term is no longer called sinusitis, it's called rhinosinusitis, because we understand that there's a big overlap between viral upper respiratory infections, and that if you do a CT and somebody's got a viral upper respiratory, if you did it in Billy, you would find all sorts of findings that are called positive for sinusitis. So most of this has nothing to do with bacterial infection. And if it is bacterial infection, supposing you have a bacterial infection on your skin that's called an abscess, what do you have to do to make it better? You drain it. Okay? The treatment of local bacterial infection is drainage. It's not antibiotics, it's drainage. The reason antibiotics work is when you can't drain something. And where it's not in a local collection. So if you had infection in your sinus, what would be the best way to treat it? To drain it, right? And if they have pus coming out of their nose, if it's pouring out, what are they doing? They're draining. So it seems to me like our whole concept of this is a little bit crazy. And if you think about the spectrum of disease where somebody's got facial pain, etc., it could range from viral disease to bacterial disease. It could range from sort of general inflammatory stuff where they're pouring out stuff, where they're going to get better, to the only sinusitis that really matters as far as I'm concerned, which is a bacterial infection that's not draining. Now, what kind of sinusitis do you see? We see pansinusitis. That's draining. There's connection. If it's in all the sinuses, it's going from one to the other. The one that worries me is not pansinusitis. It's a focal bacterial sinusitis where it's not draining. Because that's the one where if you don't do anything, you could get into problems. That's the last article in here, and we're going to get back to that in a minute. But so for me, the ones I got to worry about is not the person who has a cold, and where it might be in the sinuses as well because it hurts when they bend over and they have tooth pain. But it's the one where it's not draining and there is focal tenderness, pain, redness, whatever. Okay, on one side. Those are the ones that I'm most worried about. Now, before we get to that, let's go through some of the articles in the chapter here. So the first thing is, the first few articles say, how can you tell if it's sinusitis or not? And I just told you that this is what people think, mostly the things I told you about, bends over, face pain, tooth pain, colored snot, and I think that we should acknowledge that that's just mostly made up, okay? And most people who have that have a viral infection called rhinosinusitis. The next series of articles say, and number 5 is that as well, the next series of articles say, how good is a plain film? And some of them say it's not very good, and people don't really agree with each other. It doesn't correlate with CT. But again, without knowing the gold standard, it's hard to know what it is. Now, every one of us has seen a plain film of somebody who has a air fluid level in one maxillary sinus. That's real air fluid level. That's probably sinusitis. Might even be bacterial sinusitis. Most of the time, they're looking for little inflammatory changes. Nobody knows what that is. There is a paper in here which says you get as much information from a single Waters view as you do from a whole facial series. I don't know if anybody's getting facial series more anyway, so I'm not sure why we're talking about this. CT, you should know, 90% of colds have a, quote, positive CT. That's different than if you saw a real air fluid level in one sinus. The next thing are, how about antibiotics? How do they work? And 8 through 23 are all about antibiotics. The first few articles say, guess what? They don't work. Of course they don't work. We're using them to treat the wrong disease. We're not treating bacterial sinusitis. We're treating viral colds. Of course antibiotics don't work. That shouldn't be a surprise to any of us, right? Okay, now let's go back for a second. Supposing we had 100 people who we treated, and 95 of them had a viral cold, and 5 had sinusitis, of whom 3 had bacterial sinusitis. How would we know that, and supposing it was really important to use antibiotics in those 3, how would we know if we did a study of 100 patients? In one group, the 100 patients treated with placebo, 97 of them would get better because they didn't have the disease. And of the 3 who had the disease, at least 1 would spontaneously get better because they'd start to drain. So you'd have 98 out of 100 in that group. And the other group, which was really good and the antibiotics really worked 100%, you'd have 100 out of 100. And you get 90 out of 100 versus 100 out of 100, or maybe 99 versus 98. And you'd say no difference, right? That's called the Pollyanna phenomenon. Pollyanna phenomenon was made up by a guy, an ear guy, who used it to describe the treatment of otitis media with antibiotics. And he made the same argument. He said, since most of them don't have otitis media, the ones who do have viral otitis media, if you took an antibiotic that was great, and you compared it to an antibiotic that didn't work at all, you would need 5,000 patients in each group to see a difference, a statistical difference. Because most patients wouldn't have, they'd do exactly the same because they don't have the disease you think you're treating. That's true in a lot of medicine where we see antibiotics don't work very well. So this literature all says the antibiotics don't work. It's probably true that they don't work, but the reason is probably because most of the patients don't have the disease. And maybe they would be useful in the very small number who do have the disease, but you'll never be able to tell from this size study. By the way, even with that, the ones who have the disease, it seems to me drainage is more important than antibiotics. So I suspect they don't work for that reason too. What I love about this chapter, like many of the chapters, is that the first few articles say antibiotics don't work. The next articles, after they go through, the antibiotics don't work. And if you read these, they're pretty impressive. They don't work. After the first few articles say antibiotics don't work, the next series of articles are, how long should you give them for, and which one? Guess what? It doesn't matter which one, and it doesn't matter how long, because placebo works just as well. So I'm not going to go through all of these. Should you give 3 days or 10 days? Should it be trimethoprim sulfur versus doxy versus augmentin versus levofloxacin? It doesn't matter, because antibiotics don't work. Now, I really believe there is an occasional case who should get antibiotics. And that takes us to the last article, which I'll just tell you a little bit about, because I think it's the most important, even though it's a lousy article. And it says, who gets really sick when they have sinusitis? Who gets intracranial complications? So remember, the sinus is in the face. They're close to the brain. They could cause problems. So as far as I'm concerned, the ones we have to worry about are focal sinusitis, the sick-looking patient, usually unilateral single sinusitis, which could go to the brain. Those patients, I think, should get IV antibiotics, even some of them, even though in general, for the reason we have said, the vast majority of people with a cold don't get better with antibiotics. So there are 4 paranasal sinuses. 2 of them are really dangerous. Which are they? Frontal is number 1. Frontal is by far the most dangerous. Frontal is dangerous because it sits right next to the frontal lobe. The posterior wall of the frontal sinus is teeny, 3 cells thick, they say. So you can have direct extension. If there's a bacterial infection without drainage in a frontal sinus, the person's got a hot, boggy, red, tender area over here. That's an ENT emergency. I think those need IV antibiotics, admission, and consideration of surgery. Okay? And there's another reason, by the way, which is not only is it close to the brain, but its venous drainage goes into the sagittal sinus. So it takes infection right there. There's one other which is dangerous, which is less well described, but it's pretty well described. One of the other sinuses. Ethmoid, no. We all know it can't be the maxillary, right? It's not the ethmoid, it's actually the sphenoid. And the sphenoid is dangerous for the exact same reason. It sits right next to the cavernous sinus. And the border between the two, it's very easy to have direct extension. Sphenoid is really a problem. Why is sphenoid a problem? Because you can't press on it. You can't see it. There's nothing red, there's nothing hot. It's somewhere in there. We don't know. I can tell you what has been described as the classic presentation of sphenoid sinusitis. It is retroorbital headache going to the vertex. And we see lots of retroorbital headaches, so that's a problem. But you have what sounds like sinusitis in some ways, but they're not dripping out of the nose, because remember, the problem is they're not draining, and the sphenoid sinus doesn't have very good connections anyway. If they have a headache behind the eye that goes to the vertex, right to the back top of the head, that's something that you should think about. Now, I got to tell you that there is, the largest series I know of is 30 cases where they describe this. But all the cases which didn't look the classic way, they undoubtedly missed. So there probably are other presentations of sphenoid sinusitis. We just don't know about it. We can't figure it out. But it seems like that is the most important presentation. The reason it's bad is because it lives right next to the cavernous sinus. Remember what's in the cavernous sinus? What lives there? The carotid artery and cranial nerves 2 through 7. When you get something in there, it invariably spreads to the brain, gets cavernous sinus thrombosis, bacterial infection of the cavernous sinus, bad stuff. In little kids, the most common cause of cavernous sinus thrombosis is orbital cellulitis. In adults, the most common cause is sphenoid sinusitis. So, not common, but it's the most common. So once it's in the cavernous sinus, that's bad stuff. So you want to get it before it does there. And there is one little pearl that I was taught that it's actually worked for me twice in my career. I've tested it 1,000 times. It's worked twice, so don't expect it to work often. But if you see it, it's really gratifying. It's as follows. Cavernous sinus is right there in the middle. The sphenoid sinus is right next to it. The most lateral part of the cavernous sinus, the structure that's right there, right next to the sphenoid sinus, is the maxillary branch of cranial nerve 5. So if you have swelling in the sphenoid sinus, before it invades the cavernous sinus, gets swelling, it's going to press on V2. And so the clue is infraorbital hyposthesia. So I test for this regularly in anybody where I'm thinking, could it possibly be they got a headache? And twice in my career, the person said, normal, yeah, it feels the same, no, I can't feel that so well. And they turned out to have sphenoid sinusitis. A couple of times I've had positives that were false positives, but mostly they, no, I feel it. But it's just something you may wish to test, because if it is positive, it raises your index of suspicion, and then you would look harder. And those patients also should be considered an ENT emergency. I've only seen a few cases in my career. I've probably missed some, but that's the best I can do. So that's my reading of this chapter. I wouldn't get overly excited about it. Most of it is simple and not terribly worrisome, but keep in mind those few dangerous cases. Any comments, thoughts, questions? Okay.